We've all seen it, right? The patient who survives a absolutely brutal ICU stay, the one we fight tooth and nail for. They leave the unit, and yet they're haunted by this profound, debilitating weakness that, well, it just doesn't add up. And that's really the first big question we have to ask ourselves. Why do we see this frustrating disconnect? We look at the scans, we see the muscle mass coming back, but our patient can barely get out of a chair. What are we missing here? And this leads to an even more, well, a more unsettling question. Is it possible that our best intentions, our early aggressive feeding protocols, could actually be making things worse in the long run? Could we be jamming up the muscle's own essential recycling system, a process we call autophagy? So for today's explainer, we're pulling together the latest findings from a few key publications. These include a 2025 review in Critical Care called Muscle Weakness After Critical Illness, and a 2026 article from the Journal of Intensive Care Medicine on muscle dysfunction and physical recovery after critical illness. As always, the links to the bibliography are right there for you in the description below. Okay, so let's get to the heart of this. We're calling it the muscle paradox because it really is a tale of two different recoveries, one that we can see and measure, and another one that for so many patients is tragically missing. And the scale of this problem it's just staggering. Even when patients get that muscle mass back, up to 75% of them are dealing with this persistent, functionally limiting weakness for months, sometimes even years after they leave us. For a lot of them, this isn't just a slow recovery, it's a failed recovery. To really get our heads around this paradox, we need to think of it like a two-act play. Act 1 is what we're all familiar with, the acute storm that's raging inside the ICU. During that initial critical illness, the patient's body is hit by a metabolic hurricane. And listen, this is not simple atrophy from lying in bed. We're talking about massive proteolysis, a really specific, devastating loss of the thick myosin filaments. Those are the actual engines of muscle contraction. At the same time, the mitochondria, the cell's power plants, just go offline. And of course, our own interventions like immobilization can end up pouring fuel on this fire. But then the hurricane passes, the patient stabilizes, they leave the ICU. And that brings us to Act 2, the lingering shadow. This part of the story takes place on a biological terrain that has been fundamentally changed. And this is where the whole problem shifts. The acute storm is over, but it's left behind a scarred landscape. The issue is no longer about muscle quantity, it's about a deep, profound defect in muscle quality. What we see is this persistent bioenergetic failure, impaired autophagy, so damaged parts are just piling up like garbage, a low-grade inflammation that just smolders, and even the start of fibrosis. This concept of bioenergetic failure is absolutely key. The best way to think about it is like this. Imagine the muscle cell is a factory. In this post-ICU phase, that factory might be full of raw materials, all the glucose and amino acids we're providing with nutrition, but the power to the building has been cut. The mitochondria are damaged, the machines can't run, and that's why just pouring in more fuel doesn't restore function. So this begs the question, who recovers and who doesn't? Well, the evidence is pointing very strongly to the idea that a patient's condition before their illness acts as a kind of blueprint, really dictating their long-term recovery trajectory before they even hit the ICU doors. And you can see it so clearly here. Look at these diverging paths our patients take. Pretty much everyone has that sharp decline in the hospital, but it's after discharge. That's where their fates really separate. You see some who have a normal recovery, others who plateau in the state of partial recovery, and then there are those who face a failed recovery and end up with a significant, lasting disability. We can really think of a patient's recovery as being influenced by this triad of factors, their health before, during, and after the ICU stay. And it's interesting, we spend so much of our energy on the during phase, but the data are now telling us that the patient's pre-ICU health status is one of the most powerful predictors of where they'll end up. And this is where things get really fascinating from a clinical standpoint. Pre-existing sarcopenia, that's a massive red flag. These patients are starting with less in the tank, and they just have a blunted ability to repair themselves. But on the other hand, we're seeing a paradoxical protective effect with pre-morbid obesity. It seems that these patients are actually better at mobilizing their own fatty acids for fuel, which helps spare their lean muscle during that initial metabolic hurricane. All right, so with this new way of thinking, this two-phase disease that's dictated by a pre-illness blueprint, how do we start to turn the tide? Well, here are 3 actionable takeaways for our clinical practice. First up, we need to profile the patient, not just the illness. That means we should be assessing for pre-existing sarcopenia and frailty right on admission. And look, this isn't just an academic exercise. It lets us anticipate the recovery path and set realistic, honest expectations for them and their families. Number 2, we need to target muscle quality, not just quantity. Our focus has to shift. It's not enough to just rebuild bulk. We need strategies aimed at restoring the cell's function, improving mitochondrial health, finally putting out that smoldering inflammation, and clearing out all that cellular debris. And third, we have to orchestrate a multimodal recovery. There is no magic bullet here, folks. The best interventions are going to be a symphony, a combination of targeted nutrition for the right phase, intelligent rehab that changes as the patient does, and, down the road, biological therapies that go after these cellular problems directly. So, to pull it all together, we have to see post-ICU weakness as a two-phase problem. You have the acute metabolic hurricane that kicks everything off, followed by this chronic, scarred landscape of deep cellular dysfunction. And a patient's ability to navigate that landscape is largely determined by their pre-illness blueprint. If you only take one thing away from this explainer, please let it be this. The next time you're on rounds discussing a patient's weakness, just remember, it's not the size of the muscle, but the state of the mitochondria. That's the real battlefield where recovery is won or lost. So here's your call to action. At your next rounds, when you're talking about that long-stay patient, I want you to explicitly discuss their recovery blueprint. Ask the team, how does their pre-ICU sarcopenia or obesity or their frailty change our expectations for their long-term functional outcome? Just start that conversation. Disclaimer and bibliography in the description.